Hello everyone, and thank you for inviting me to present to you today specifically on how our team chose sensory screening tests for nurses that are working in long-term care. I would like to acknowledge that this work was done by a larger team that is all linked to the Canadian Consortium on Neurodegeneration and Aging. I also quickly want to say thank you to the organizations that give us funding. However, in this case, for today's presentation, I don't have any conflicts of interest to declare. It turns out that when we look at combined vision and hearing difficulties, it remains difficult to estimate really what proportion of the population over the age of 65 is affected. In this specific literature review, we can see that depending on the study sample and the location and the type of approach, the estimates range anywhere from about 3% all the way up to 38%. And in a way, all of these are correct because they are, of course, looking at a very specific population. We generally are in agreement in the community that combined vision and hearing difficulties increase with age and are highest among centenarians or individuals that have a hip fracture. The reason we're talking about sensory health is because interesting things happen as we compare prevalence across different populations. Here's some work from Ontario where we're looking at home care, and it turns out that individuals that are receiving home care, the largest group are those that have hearing loss only, followed by those with vision loss, and then there's a smaller proportion of individuals that are living with dual sensory loss. But there is an interesting reversal that happens when we look at the context of long-term care, because now combined vision and hearing difficulties are actually the largest group with roughly a quarter of residents. And if we add all the individuals with any kind of sensory difficulty, we're looking at about 2/3 of residents in long-term care that have a sensory difficulty. If we now dig a little deeper, and also introduce the idea of cognitive impairment, what ends up happening is that in long-term care, the picture is quite different than in home care. In home care, there is still a substantial amount of individuals that have no sensory or cognitive difficulties, and if they do, they may have one, but it turns out roughly about half the population lives with a combination of two of those, whereby the biggest chunk are those with hearing and cognition. And then there is a substantial number of individuals living with a triple impairment where vision, hearing, and cognition are affected. But this distribution changes and shifts as we look at long-term care, whereby no impairment is relatively rare. Single impairment is mostly cognitive impairment. Makes sense, it's also often an admissions reason for long-term care. Then we have a big chunk of individuals with two impairments, which are generally combinations of vision cognition or hearing cognition, and then of course a much larger proportion of individuals that live with cognitive and combined sensory difficulties. The next question that I ask as a researcher is when any of this is true, because these numbers may not be accurate, specifically because they may actually be underestimates of the level of sensory and cognitive difficulties, specifically in long-term care. The individuals that are residents in long-term care are often a neglected population. They may be difficult to recruit. They are not studied or they're not considered at all in larger studies simply because of their environment. And then if they are considered, we wonder whether they are sufficiently accommodated for the needs that they may have to be included in research. Now, the importance of being able to identify sensory loss in all populations matter, and so it was a goal for us to specifically include this population, no matter how marginalized they are. So, if you want to serve those with sensory difficulties and that are living with dementia in long-term care, how do we need to make this happen? What can we do? So we ended up developing a package of sensory tools that I will introduce today that is specifically designed for long-term care. We focused on nurses at the time, but I would argue that the target audience can be much larger in terms of professionals or also non-professionals. to see whether they can detect potential reasons for referral to other health specialists in sensory care. All right, so I also want to sort of make a philosophical stand before I head into this work with a shout out to Kathy Magilton and her PhD work at the time, because she introduced me to the concept of relationship building. When I started in this context, I did not really know that much about long-term care. This was also before I myself became a care provider for my mother-in-law, who was living with us with dementia for a few years, and who now also has moved to long-term care. And so my perspective, my experience has changed, and I started to better understand that long-term care residents really live in this environment. This is their home. Therefore, they build relationships with other residents, with the care providers, with the people that come to visit. And so this relationship building gives a different spin on the idea of why sensory health is important in long-term care. What I will go through today is a series of studies that were funded under the leadership of Kathy Magilton for us, and it will show you how we ended up with this evaluation tool that I will show you at the end. If you have too much time, of course, you can look up the very detailed publication of our protocol that is available in open access. The first study we conducted was a series of scoping reviews. The first scoping review specifically focused on screening for vision in long-term care. And what I've done here is you will see in the red bracket the kind of tools, tests, and strategies that are used that have very much a physiological, medical, or behavioral performance focus. There are very few that are much more based on a subjective approach, in this case questionnaires, and that may also more get at items that are relevant to relationship building. So this is why I will always come back to this idea: are we actually using an approach that is relevant to the residents in long-term care to facilitate relationship building? We then did a second review which focused specifically on hearing. You will see here that the proportion of the physiological, medical, and the behavioral tests is a little bit smaller compared to measures that look at communication specifically. And that makes sense in the context of hearing, since hearing is intuitively more about communication than vision, even though, don't underestimate audio-visual communication. Vision plays an important role in speech perception, for example. I want to also quickly point out that during this search, we ended up discovering that there are 3 measures that span vision and hearing. The Interride tools specifically consider both vision and hearing together. They are included here, but it is quite fascinating to see how rarely actually dual sensory loss is considered within the measurement process, given that the compensations that are necessary for one impairment with the other are not considered in any of the measures that I've reported here that are specific for vision or hearing. The next study we conducted was an environmental scan where we approached nurses that specifically work in long-term care, and we asked them what kind of tools and strategies they implement to get a better idea of the vision and hearing abilities of their clientele, of the residents in long-term care. And you will see that, again, I highlighted them here in green. There are fewer compared to what we would otherwise use or categorize in the more medical approach. There are a few. There's some vision questions, questionnaire items, ways of assessing how vision and hearing operate. It was also interesting to explore what their priorities were, because both for screening and for communication, they have very specific approaches to get at sensory functioning. The next study was an environmental scan with specialists that work in sensory care. They may not necessarily be working in long-term care, but they have some experience. These might be audiologists or optometrists that often visit long-term care in order to do on-site assessments, or researchers that have experience working with this population. And again, you will see that there are many tools and strategies that are reported as useful in long-term care, but the ones that relate really very clearly to communication and relationship building are still in the minority. So the next step we took is that we now pooled all the information from these 4 studies that we conducted, the scoping reviews and the environmental scans. We created long lists of all the vision tests here at the top and the hearing test at the bottom. And we then sent this out to a large group of specialists, nurses, experts, people that helped us with their expertise in this process. And we asked them to rank these tools for their usability, their usefulness, potentially also their feasibility in long-term care, to see which ones scored best. Feasibility was an important point here because, of course, nurses don't have much time. So if the test is too long, it may not work. If this is a test that requires expensive equipment or equipment that is difficult to carry around, this may not work. And so we really looked at what are the most viable and feasible screening tools that could be used in everyday practice in long-term care. We then ended up developing a protocol to actually try this out in an applied context. Here is the validation, the tools that we ended up using in the validation process. So you will see that both for vision and for hearing, we put together brief hearing and vision screening questionnaires. The screening questionnaires for vision, the items would be easily recognizable from many intake exams that would be done across different professions, but they basically are questions that ask about visual functions. It turns out visual acuity, especially if it is near visual acuity, was deemed useful and practical, also because if people have a small portable acuity chart in their pocket, this may also be viable to do. Counting fingers and hand motion, as well as confrontation fields that look at the ability for individuals to detect visual stimuli that enter the visual field. That was very possible as well, because it doesn't require any equipment. When we looked at the screening tools for hearing, we actually discovered that 2 of the validated questionnaires scored quite high because they can be completed or are completed by staff. The other items that emerged was otoscopy, which is basically checking for wax, an important piece of the process since a lot of hearing difficulties can be resolved through the removal of earwax. And then there were a couple of different hearing tests, including the whisper test and the finger rub test that were suggested. We learned a couple of interesting things as we look at the feasibility of implementing this testing procedure. It turns out what we ended up doing is we recruited 17 participants, and then we asked sensory specialists, specifically an optometrist and an audiologist with extensive experience in the long-term care environment, to administer all of these screening tests. We also then asked nurses on staff to do exactly the same thing, and then we compared whether things worked and what happened. So what you will see here in this table is the green check marks are the items, are the individuals who were successfully screened by the specialist and by the nurse. And it turns out that the pattern we see here as we go down the table, you see that we have more yellow boxes, more red boxes where things did not work out as well. And what we ended up doing here is we sorted and ordered our participants by the severity of the cognitive impairment. So the indication here is that as the severity of the cognitive impairment is increasing, the screening for sensory difficulty becomes a little bit more difficult to do or to be successful. However, the good news is that even with some individuals with severe difficulties, it was possible. So don't give up, because there is hope. So the feasibility depended very much on the severity of the cognitive impairment. As a general basic assumption that came out of our work is we simply say most residents will have some level of sensory difficulty, so you can simply assume that. If possible, you would want to determine the need for sensory care or for the different types of accommodation at the admissions or at the first testing sessions when people move into long-term care, because it will inform care planning. All staff members should know about sensory difficulties to simply facilitate communication. Of course, you would then want to figure out whether this is something that you can repeat over time, simply because that will update care planning as you go forward. It will provide ongoing information if that is possible. So what can be done? Of course, the three items that I always start out with is you want to establish the capacity of the residents and adapt the screening as much as you can. You want to then, as a function of these screening outcomes, improve functionality, whether that is person-centered care with an interprofessional team or some other approach to increase people's ability. You also want to increase accessibility of the environment, whether that is the usability of products or services or an adaptation to the environment. With a quick nod to our Team 17 members, I always like to point out a few things that are potentially intuitive but are worth reminding. When you communicate with individuals with hearing difficulties, you don't want to yell, you want to simply speak clearly, as that will make a big difference. Communication is easily facilitated by giving context. So simply pointing out that you're now talking about lunch, then you know whatever vocabulary will come thereafter will relate to lunch and eating. If there is a communication situation where it is important that people really understand what you're saying, the easiest tool is to simply ask them to repeat it back to you, because then you will know whether there has been a problem in receiving the information. Some of the environmental adaptations that are easy to avoid are glare, provide large print, avoid noise whenever possible. And noise can be something simple as the sound of an air conditioner. It just depends on how much it interferes with communication. Probably the most expensive recommendation that I will make today is to allow for more time. Individuals that live specifically with combined vision and hearing difficulties will require more time to process things, because everything is a little bit more effort. So if you have the space and the time in your professional day, adding that little bit of patience will make a big difference. I'm very happy to report that many of our recommendations were absorbed into the process within the Canadian Long-Term Care Service recommendations, the national standards, because the timing worked out in such a way that we were able to submit this before the deadline in 2022, and so you will see that vision and hearing are included in the recommendations specifically for communication. I also want to quickly remind people that prevention is often extremely important here, because sensory difficulties are often related also to admissions and also related to increase of dementia risk. So keeping the senses in good shape may avoid multiple other difficulties as well. In this prospect, in this context, our team often speaks of the ICOPE, the Integrated Care of Older People model that comes from the WHO, the World Health Organization. It's a wonderful handbook with guidance on person-centered assessments, specifically designed in primary care, but it has a wonderful package of screening tools that are easily implemented across different environments, because none of them require much effort or much cost. So I encourage you to have a look at the ICOPE specifically. I also want to send a quick shout out to Team 17, our interdisciplinary team that has worked on many of these topics. And I'll encourage you to look for the Canadian Consortium in neurodegeneration and aging, because there are lots of wonderful resources developed. One of the items that we often talk about within the ICOPE approach is that the goal of rehabilitation is to elevate individuals' abilities from the intrinsic capacity that they may currently have to their potential functional ability through things like rehabilitation. The trifecta we often talk about is the adaptations to the environment, the introduction of technology, and the adjustments of expectations, simply by educating people about what is possible. Brain Health Pro is one of these approaches that was supported by the Canadian Consortium for Neurodegeneration in Aging, and it is an online training program that we've been working on. This shall soon, I believe, become open access, and it might become a wonderful tool to explore potentially modifiable risk factors. The model examines 7 risk factors that have been identified that can potentially be modified in dementia risk, and it is a program designed to increase dementia literacy. We also have a project going on currently at Maimonides here where I'm presenting today, where my colleague Michelle Wilczewski and I were able to obtain some research funding and now expand our prospect from only supporting nurses, but also to support regulated and unregulated care providers, whether these are companions, family members, or other individuals that may not have a professional order. This work is currently going on, and I hope to be able to report to you on that at some point in the future. Here are some of the early items. We found it, for example, very, very fascinating that only about 14% of the staff that had decided to participate in our study had received some type of formal or informal training on how to communicate with individuals that live with sensory difficulties. And of course, it is therefore not surprising that sometimes people simply don't know what to do. It was also interesting to see what types of priorities were identified by our participants, but as I said, we will go into these data with more depth once our study is complete. I want to thank you for your time today and for your interest in sensory care and long-term care, and I look forward to presenting to you some of these preliminary findings the next time I come back. Bye now.